All right, welcome everyone. I hope everyone can hear me, and I hope I can be informed if anyone doesn't hear me. The reason I'm standing slightly back from the computer is because it's running off the computer, and you have to stand here for the people online to see you. So thank you for coming. For those of you who don't know me, I'm Leslie London, and we are very pleased everyone's been able to join, many online, to talk about this project. It's highly choreographed, our presentations. I hope it all works out well. You'll see a page in front of you. It's a project which we are presenting, which is part of a network. It's called Strengthening Health Systems Capacity for Pandemic Equity and Responsiveness, SHARPA. And it's about characterizing the health research environment to ensure population benefits flow from health research. The rationale is that we know in Africa, health research is really important for health outcomes. There's a lot of research conducted, but populations in Africa do not benefit. And that was classically illustrated in COVID. That's a cartoon from one of the national newspapers, which illustrates how what happened during COVID, that the vaccines were developed very rapidly, but not everyone who needed it, in fact, the people who needed it most didn't get it. Problem is most ethical oversight systems we have focus on individual participants, whether they are protected or being harmed, and it doesn't really think about the population from whom those participants come and the benefits to that population. And for most part, it ignores African values in its deliberations, ideas of communality, identity, Ubuntu, etc. At the same time, in the human rights framework, we should all enjoy a right to enjoy the benefits of scientific progress. That's a provision in the Covenant on Economic, Social and Cultural Rights, which most countries have ratified, including South Africa, but it's a very overlooked right and often not operationalized. And it's not evident in the current pandemic treaty processes, which Lauren will speak about shortly. So this project arises from a call made by the Science Foundation for Africa as part of an Africa Science Pandemic Science Collaborative. Marlise picked up the call much earlier in December 2023, and after a long process, we were finally awarded the grant as one of 7 Epsilons, Epidemic Science Leadership Innovation Networks in Africa. And I will have a slide at the end just to share who the other Epsilons are. So it took quite a while. We commenced in July last year, so we're still quite early in the process. It's a multi-country collaboration. It involves a PI, Professor Ajuwan, in Ibadan University in Nigeria. We have collaborators in Uganda at a local health NGO cum training institution, in Kenya at the Tropical Institute of Community Health and Development, in Cameroon Bioethics Initiative, and Cynthia is here from that institute based at UCT. Can I ask whoever's online to mute? Are you able to mute? Muted. And then Malawi and Cameroon. Okay. And then at UCT, myself, Marlise, Lauren, and recently Swabavika's joined the team. So the objectives of this project are to do an analysis of the policy landscape for research, meaning the legal, academic, scientific, regulatory, ethical, and advocacy mechanisms and opportunities in the countries. We will do 5 country cases. We will look at research nodes, research networks. Many of them exist in Africa. We want to look at current and past practices in ethical oversight, addressing population benefits. And we want to explore how African norms and values should shape the ethical and regulatory environment to emphasize collective benefits from health technologies. So classically clinical trials, but there's many other forms of research. Scoping studies to identify the strategies to report in the literature to address this gap, and then evaluation of any interventions for ethical oversight that strengthen capacity. It's a 6-year project. There are different work packages, and for instance, characterizing the research environment, characterizing the problem and the ethics landscape is one package that UCT will lead. Characterizing the global human rights context is a package Afna Yahaki in Uganda will lead. Package on African norms and values is led by Camben from Cameroon. The acting on the research through training is University of Ibadan, which will also look at take care of the networking and strengthening the capacity of researchers. And colleagues in Kenya will look at advocacy and policy change, and in Malawi, the monitoring and evaluation. So the idea is we start with what is the normal ethical oversight environment and why does it fail to deliver? And then we work through to try to change that. And that is the way we have structured the project. Okay, so that's the introduction. And I'm going to hand over to Swabavika.
Good afternoon, everyone. So for all of you in person, there's a page in front of you, and we're going to go over a case study. Online, we've got it reflected there. So I'm just going to read through it and... I think it's now projected online. So I'm going to just read through it quickly, and we'll give everyone 2 to 3 minutes just to have a bit of a discussion, to answer the 2 questions, and then we'll just hear from you what your thoughts are. So this is a case study on artificial intelligence guided screening for cardiomyopathies in an obstetric population. It's a pragmatic randomized control clinical trial. A protocol is presented to a Nigerian University Ethics Committee to evaluate AI-guided screening for cardiomyopathies in an obstetric population using a pragmatic randomized clinical trial. There are 32 collaborators on the study from 9 different institutions, often different departments in the same institution. Both the first PI and senior researchers are from the Mayo Clinic, but the first lead researcher on the study is a Nigerian non-invasive cardiologist working as an assistant professor at the Mayo Clinic. Of the 8 other institutions involved, all but 1 are Nigerian hospitals or a university, and 1 is a UK collaborator. More than half of the co-authors are clinicians working at the various field sites for the study. The study proposes to compare the effectiveness of AI-enabled digital stethoscope detection of a cardiomyopathy as defined by left ventricular systolic dysfunction compared to the clinical recognition and documentation of LVST and echo in keeping with current standard of care. 600 pregnant women and postpartum women are recruited in each arm in an open-label, randomized, pragmatic clinical trial across 6 clinical sites across Nigeria. All cases will have access to appropriate referrals, including those previously clinically unrecognized, by ensuring that each study site is led by an obstetrician, gynecologist, and cardiologist as co-principal investigators. Study participants will also receive the results and interpretation of all testing in the perinatal period. Recruitment will be preceded by individualized informed consent procedures in the language of choice of the potential participants, consistent with national ethical guidelines for Nigeria. Under competing interests, it's noted that the researchers note that the AI algorithms, which include screening for low ventricular ejection fraction, QT tools, aortic stenosis, and atrial fib detection during normal sinus rhythm, having been licensed to 3 commercial entities, namely Anumana, AliveCore, and Echo. Both the Mayo Clinic and a number of the researchers acknowledge that they may benefit from their commercialization. 5 of the researchers, all based in the US, 4 of which at Mayo Clinic, report various interests, such as filing of patents related to the application of AI to ECG for diagnosis, advisory board service, receipt of royalties, and grant funding. So the questions we are asking for today is, from what this very brief summary presents, do you think the participants are fairly treated in the study? And as an ethics committee member, do you feel the study will benefit the Nigerian population at risk to pregnancy-related cardiomyopathy? So we'll just allow about 2 minutes and everyone can discuss, and we'll come back to what your reflections on this were.
You can ask those online, you just put in the chat.
Okay, online, you can just put it in the chat and then I will read that out. Thank you.
We talk to the person next to you if you like.
Okay, I think we can start the discussion. We will start with the online question.
So there's a question from Rachel that says, I need more information regarding how people access healthcare in Nigeria to answer.
Okay.
And then you want another one? Wendy says, I don't think I can fully answer that in the affirmative with the little information presented in the summary. Possibly the participants in the study are number 2, but without info on whether the technology will be accessible later, which is unlikely, then likely not.
From whom? What are the thoughts?
That's a basic clinical question. How severe is the doctor? Sorry, not a medical doctor. How severe is this issue during pregnancy?
Heart failure.
It is hard
Basically, heart failure can be quite serious.
Yeah. I was going to Google it. Okay.
It wasn't clear whether when this AI tool gets developed, what access there would be for the community that on humans being tested. For me, was the biggest issue. And obviously that the researchers are going to make money from their patents. But I suppose that could be dealt with conflict of interest statements, etc. But for me, it's not clear. I don't know enough about how healthcare is provided in Nigeria and whether there's a
So,
Yes, so I thought about representation from the participant population as part of the research collaboration research team. It's not clear whether there is of that representation from the population so they could share their views or perspectives on the whole research process.
Yes, that's important.
And if I could add to that, now that I know it's heart failure, it's just to say that how that is explained, like this trial and then a referral to that, it says referrals as appropriate referrals. Like what does it look like? Because it's quite a serious detection.
Yeah, so all those are important. We need more information about how it will be shared. Often there's usually in a protocol saying that we will provide some training or education to the clinicians who are assisting, but is there enough information where we can actually say that there'll be a population benefit from it? And there is a part where usually as part of a clinical trial, we have to be referred if a patient is picked up with having the seriousness, but it's always, like Prof was saying, at an individual level, and how you would address what is happening individually versus we need more information is that once the trial is done, once we have the results, we know that in terms of the competing interests, they're very interested in the marketing aspects of it, but what is the population benefit to the actual people who it is being trialed on? Any other inputs before we close?
Can I ask a question? You seem to emphasize that the co-investigator was a non-interventional cardiologist. Is there a reason for that?
No, it's just to say who these people are. Marlise, any more on that?
There's one participant that says the answers depend on the cost and availability of an AI-enabled digital stethoscope in Nigeria. And then Maylene says, depends on how results are shared with participants and whether there will be a supportive counselling environment when they receive their results. And will patients be able to interpret their results on their own? And Tandy says, I think the technology will benefit the Nigerian population if there's a clear plan for affordable local implementation and ease of access.
Yeah, so all those points was what is the plan, how will access be? And another thing with AI, which is really important, is that what algorithms are they using and was it from the population that they're actually studying in? So yeah, thank you very much for the input.
So, good afternoon, everyone. My name is Lauren. And I think one of the things that's important to note is that everyone has intuitively answered the question on the slide. So in response to the case study, there was a discussion about how participants in the trial are treated, but also several reflections on population level benefits. And so one of the concepts that we use in the context of the study is the concept of benefit sharing, which is the idea that the burdens, but also the net positives of medical research or scientific research more broadly should be distributed equitably. And one of the ways in which benefit sharing is thought about increasingly is that it should be operationalized as contractually binding, so that it can take the form of a legal contract or a set of formal commitments that are enforceable, that ensure that there is a plan. I think someone in the previous section mentioned, what's the plan, right, for ensuring ease of access? And so the idea is that benefit sharing isn't just normative, but also that it's a kind of binding contract and commitment. And I think if we look at this from a Global South perspective, that's particularly important because in scientific research, and this includes clinical research, but also medicines development and so on, there is a history, I think, of biopiracy and resource extractivism, which the image kind of captures. And the idea is that, you know, to end that, access to natural resources, pathogens, bodies in clinical trials should be placed on an equal footing to the benefits generated as a result of that access, and benefits can be monetary and non-monetary. So in the context of South Africa, I'm going to look at two case studies. The one is the lenacapavir trial for long-acting ARVs. I think in terms of the first question in the slide, one of the key things that happened during the trial was that the trial was conducted in South Africa. And so the data produced drew on knowledge from South Africa, but also there was a trial in Uganda, for example. The intervention proved very successful, extremely successful, in fact, in preventing the transmission of ARVs, of HIVs, HIV. And the obstacle, I think, in terms of proving successful to prevent transmission is, of course, that access to lenacapavir has been highly contested in South Africa. So there's been a struggle to purchase lenacapavir at an affordable price and then subsequently to get a license to produce it. There has been a second call for tenders to manufacture locally, and that went out, I think, in March 2026. So in terms of population level benefits, really that has fallen short in the context of this clinical trial. What are the anchors for making benefit sharing claims in relation to lenacapavir? One of them could be the WHO clinical trial resolution. So it's a resolution adopted at the 75th Health Assembly, and that basically argues that we need to couple medical research to a level of benefit sharing for populations. In the resolution itself, it's not operationalized very concretely, this idea of benefit sharing, but civil society organizations like MSF have suggested quite concrete measures. And so some of them include registration of dossiers with regulatory authorities in places where trials were held, having price or profit caps, and also signing up at the beginning of the trial to issue voluntary licenses to local manufacturers. And the premise on which that benefit sharing argument is based is that actually when we think of scientific knowledge production, there's a whole community, a whole ecosystem that contributes to it. And so all of the people listed in the second last bullet point can be acknowledged, but also enjoy the benefits of research when we enter into these kinds of benefit sharing arrangements. The second example relates to the pandemic agreement, where we saw South Africa sharing the Omicron pathogen, but instead of receiving benefits, we actually received, one might say, blowback, including travel bans and inadequate access to the vaccines that were tested for efficacy on this new version of the pathogen. So at the global level, what's happening is that there is an ongoing negotiation for a pandemic agreement, and that the mandate for those negotiations is to propose practical measures to operationalize equity and solidarity in the context of PPR. One constraint with the process is that if the first component concluded in May 2025, it has several clauses that suggest measures that could promote equity, but none of these are legally binding. They all ask governments or the World Health Organization to undertake their best endeavors to, for example, place conditions on publicly funded research. There is a second part of the process that's been running since May 2025 and is due to conclude in May this year, and that concerns an annex on pathogen access and benefit sharing, where benefit sharing is supposed to be operationalized according to quite specific metrics. And one of the things to think about is actually that these negotiations have been quite rough from a Global South perspective. The Africa Group has made many proposals which are aimed at specifying which benefits should be included, but these have met with a lot of resistance from the EU and Norway. The PABS Annex, as it's called, is premised on the legal principle that pathogens are the property of sovereign states. And this is the principle in international law. They therefore should be able to set conditions, legal conditions, on the terms on which pathogens are accessed. And that benefit sharing shouldn't be vague, but be tied to quite specific obligations. This I'm going to skip over. And then just focus on this slide, which lists examples of the benefits being negotiated for during these negotiations. So they include guaranteed access to tests, treatments, and vaccines. They include licenses being issued to developing country manufacturers, limitations on patentability, data sharing by scientists that might access pathogens but not be interested in commercialization. Another kind of benefit would be to share the data set. And then, of course, monetary contributions, so a kind of subscription fee, perhaps, to be able to continue accessing pathogens from a database. And this applies particularly to pathogens with pandemic potential. I'm going to close on this slide, which is a cartoon that was developed by an advocacy organization reflecting on the PABS Annex negotiations. And the basic premise is that there's an argument for open science being made. And the premise of the cartoon is that open science should be open all along the R&D value chain. So if we're openly sharing pathogens, we should on an equal footing, also open up equitable access to the benefits of scientific progress. And so that obviously doesn't happen when we privatize the vaccines, diagnostics, and whatever else results from pathogen sharing. So maybe just to add as a final comment, one of the things that's important about what's happening on the continent is there are new institutions like the African Medicines Agency and the Africa CDC that could be used as sites for negotiating benefit sharing agreements or regulations that apply on the continent to move this ahead.
Cynthia, do you want to say a few words about the network? But you'll have to say it from the front, otherwise they won't hear you.
Right, so good morning. I have a cold, so I can't speak out loud, but for the work package, I think it's work package 3, it will focus on African values in pandemic preparedness and response. So we basically just want to situate the arguments around population level benefit sharing within African norms and values, and to say how can the African voice get into the global bioethics space. So that's happening, but perhaps also the words we use, we understand them differently. So for example, everyone agreed during the COVID-19 pandemic that solidarity is important, but I think we all understood down the line that, well, the way we talk about solidarity is different in other parts of the world, so our expectations of benefit sharing in the end were quite different, and that raised some amount of tension, but that was because we all understood solidarity very differently. So that's some of the work that we'll be doing, and then also test those values and principles from African frameworks. I think we will try to learn. Much work has been done in that space for Ubuntu, eco-biocommunitarianism, for genomics, and One Health. So we'll try to apply some of those frameworks to see if it works for research during disease outbreaks. So, yeah.
Maybe I can do it.
Thanks. For those who don't know me, I'm Marianne Davies. I'm part of the Division of Public Health Medicine, and I think because of the COVID pandemic, a lot of things got sparked in terms of the pandemic research space, and one of those is that the NRF in South Africa, together with the DSTI, invited universities to apply to be the Institute for Pandemic Preparedness and Prevention. And that resulted eventually in an application from 10 South African universities, and only universities were invited to apply. So that's why they know in the consortium, there are no other partners, but they applied and successfully were awarded funding to work with several partners, which is still part of what we are developing, to be an Institute for Pandemic Preparedness and Prevention, or IP3. And so you may have heard about it or will hear about it. And obviously we know that there are a lot of other people working in this space, but we are trying to be an institute that can be kind of a place where some of these networks and collaborations can form, and where we can partner with other groups like Sharpa. Just to very briefly outline, the idea of the Institute is to kind of work end to end on research in the pandemic preparedness space, ranging from identifying pathogens in the environment and in animals, that's the yellow, pandemic prevention, moving through to epidemiology in humans. That's the kind of science that got shared and resulted in some of the negative consequences that Lauren's talked about. Development of preclinical development of tools to address pathogens, as well as clinical, and then platforms for clinical trials that we've talked about, looking at impacts on health systems and research to strengthen health systems, both to respond to pandemics, but also to deliver the interventions that we might get access to if we get the research and the agreements right. and then the impact of pandemics on communities. And I want to highlight that Ilona right here is leading that theme. There are also two what are currently called integrated platforms, but we might call them something different because it's confusing having two acronyms with IP in the same institution. And so one is looking at cross-cutting technologies, because obviously there's a lot of overlap in the tech that's needed to support particularly TC 1 to 4. And the other, which is the most relevant to Sharper and where I'd really like to engage with you and get the researchers who are involved in this thematic center involved, is what are called enabling conditions. So that's really looking at the legal governance and ethics frameworks that are needed in pandemics. And I will finish with one slide, which is just to show you the range of different areas that these groups are involved in and the current leads. And you will see many of the familiar names who were our science rock stars during the pandemic on that list. So we really are trying to include, but also expand and diversify the network as we grow. Thanks very much. And I'm here because I'm the interim director of this organization, so that's my role. And there are a couple of people online I checked who are also involved, and many of these people are also recipients of Epsilon grants. Thank you. I haven't saved my allotted minutes.
So we try to share with you the work of the IP3 so that you understand there's a lot going on in the space, and I'm just going to end with this slide, which is the 7 epsilons that are funded through this consortium, the African Pandemic Science Collaborative. There are 4 at UCT, 2 as PIs, that's Ginal Beeman and Sheetal Silal, who some of you will know, and their projects focus, Sheetal's a modeling focus, and Ginal's more kind of laboratory focus on virology. And Paolo Denti is the local PI for a project on clinical research and clinical trials on epidemic and pandemic-prone infections. And I'm the local PI for the project led by Professor Ajuwan from Ibadan. So this is an idea of the SFA to create basically a community of practice, community of science across Africa and develop young researchers. It has a whole set of plans around workforce development. It is funded through various sources, but from the MasterCard Foundation, which is also funding work at UCT. So its focus is on youth and careers and development and opportunities. But in the health context, it's about developing young African scientists. And there will be opportunities available for sort of cross-cutting Catalyst Awards, which are kind of small research grants, research fellowships, Epsilon exchanges, and some of you will have seen there was recently an advert for a fellowship, which is not directly linked to each grant, but through the SFA for work on pandemic preparedness. So we've choreographed this down to 35 minutes, and now we have time for questions and discussion, and I hope there will be a lot. Marlise, can you keep tabs on the... Okay, any comments or questions?
There's a lot from the online participants.
There we go.
I see his son has got his hand on up. I'm not sure if we can do audio.
Yeah, we can.
Do we? Okay, Hassan, do you want to go, and then I'll read through some of that?
Yeah. So I've posted something in the chat. You know, the area of outbreak response measures, things like isolation, quarantine, vaccination, just feel the effectiveness of this is not adequately researched. So I wonder if there's any plan to focus on this. Thanks.
Perhaps we can take a few questions. Are there others?
Paremoer is online.
Paremoer, welcome. IPR, my leader.
How are you?
I'm good.
I hope you can all hear me. I want to seize this opportunity to congratulate the entire team, Leslie, Marlise, and Lauren, for this wonderful presentation. Well done. We are really proud of the presentation. My comment is just to say well done and congratulations. Over.
Okay. So the reason I told Emer I'm wearing his shirt is because when we arrived at our first project meeting, he organized a tailor, and every member of the project got a shirt towards the end of the day. So when we met the Vice Chancellor, we were all in uniform. I hope you noticed that, Emer. I was wearing this. Any other comments?
I noticed that you are wearing the shirts.
Yes.
Thank you.
Thanks, Ademola. And maybe to respond to Hassan, our focus is on how do we make research work for the population? And I think your question is about the choice of research. And maybe there are certain things which don't get research for various reasons. I suppose what we are focusing on is more where research actually produces benefits that gets hijacked somewhere else and doesn't come to populations. The fact that there isn't research happening on the effectiveness of many of these measures is a problem. It's not so much going to be our focus, but I think it might be the focus of IP3. Am I correct?
Yeah, we don't have a project in that domain at the moment, but I think that is planned for the first 3-year cycle. And probably partly because the funding from the original proposal to what was actually received was so limited, and I think that kind of research would need substantive funding. But I think it is a brilliant area for us to look at, particularly with the multidisciplinary lens. So having, the community perspective on these interventions as well.
Hassan, I don't know if you heard Marianne.
Yes, thanks.
Yeah, that's good. So I think, what was I going to say? So, during COVID, there was a lot of pushback for many of these measures, and it was contested space. So people said, no, the lockdown's worse than the consequence of infection. But there was no evidence for that. So I think Hassan's highlighted an important issue, and maybe it will get picked up as we go forward. Okay.
May I add something? So maybe in terms of the PEPS annex negotiations, one of the things that reflects that kind of political difficulties with benefit sharing is that at the moment, Global North negotiators are only willing to give benefit sharing specifications for pandemics. The Africa Group and Central African Republic in particular are saying we need benefits that specified access to vaccines, diagnostics, therapeutics during outbreaks, and public health emergencies of international concern. There's reluctance for that, but if you look at it from a public health perspective, it's completely irrational. So perhaps there might be benefit sharing commitments on PHEICs if we're lucky and the negotiations go that way. But at the moment, specific volumes, donations, for example, during outbreaks, are not even on the table. And so that's the kind of political difficulty, unless we have perhaps regional frameworks that can specify benefit sharing even during outbreaks and PHEICs.
So, and just to add to that, our study on AI diagnostics wouldn't feature there, because it's not a public health emergency of equity proportions. Okay, I can see Wendy online, but do you want to take it?
Yeah, it was just linked to this. So I guess I'm wondering how, like, in the example Hassan raised, the benefits to private hotels was massive, in the millions and millions and millions nationally through those tenders. And that was based on inadequate science, that those beds, I think the bed occupancy rate was 30% max in those hotels. So I do wonder, like, how, if those sorts of, like, I don't know what we would even call this, like broader sectoral spin-offs within pandemics is something that fits into this, or it's a bit far outside of it.
Okay, well, it's game for us to consider. See how we can, maybe we'll find a PhD student to take it up. Wendy, you've got your hand up?
Thanks. I just want to say this is a very exciting project. Thanks very much for the presentation. So you mentioned biopiracy, and that made me think of the Nagoya Protocol, and because it's also about benefit sharing. But in that case, it's slightly different because it's the IP that belongs to it's giving the IP rights back and the benefit sharing of the people who actually had the knowledge. Whereas what we're talking about here is often someone else comes with their IP and it gets tested in our populations and then they don't benefit. And it makes me think, beyond pandemic treaty, that there should be a protocol like Nagoya, right, for clinical research of any kind, because even if it's like a phase 1 trial, this is still not an effectiveness trial. So there's no guarantee that there will be something of benefit at the end, right? Because it's still very early in the pipeline. But people should still, there should still be benefit to the country because it is still bodies, expertise, capacity here. And, the one thing I was talking to a few people was about like paying some kind of premium into like some kind of fund, whether that's used for healthcare or conducting our own clinical trials, because that's often, the things that now we're starting to manufacture here, they're so difficult and expensive to run the trials, because it's often the trial and the product is coming, the sponsorship is coming from abroad. So there's like levels of sovereignty here that we could potentially build towards if there's this kind of, I don't know, a tax or something run by reputable people into a fund. These are, I don't know, some of the things we've been thinking about.
Not our Director General, actually. So you've sparked a lot of responses. So I think Lauren and Elena want to respond. Lauren?
Yes, so actually, you're right that there's a difference between the pandemic pathogens and other scientific research. In the context of the PABS negotiations, the Nagoya Protocol is the hinge for the claim that pathogen access and benefit sharing should be placed on an equal footing, and that's because the pathogens and also digital sequencing information under Nagoya are recognized as sovereign resources of states. And one of the benefit sharing examples that are referenced in relation to that is the Pandemic Influenza Preparedness or PIP framework. And that does ask, whoever accesses the influenza pathogens to make monetary contributions that can be used for surveillance, strengthening, and so on. So that's one model in the context of pandemics, and then hinged on this international right associated with Nagoya. But I think, as Leslie mentioned, our focus here is also on other kinds of scientific research. Now we can use IRBs, ethics bodies, ethics regulators at national and regional level to gain access to clinical trial benefits. And the idea there might be, because you're right, it's not clear whether there will be any benefit. But an idea there might be to echo something that's being asked for in the context of the PABS negotiations, which is that any benefit sharing contracts are concluded at the beginning of the research cycle. And it's an in-principle commitment. And that is so that the powers that negotiate the contracts are equal. And you're not negotiating from a position of weakness later on when commercialization is set to take place.
So if I could just add to that, there are two responses. One is an ethical guidance response, which says this is how you should do things. The other is a rights-based approach, which is to say that states have obligations to deliver science benefits to populations. And if that means setting up an institutional framework that says you have to agree up front on how this is going to work to benefit the population, then it makes it easier for researchers to say, okay, to the sponsor, how's this going to work, and push back. The moment researchers don't do that, or they say it's not their responsibility. So, Elena?
I'm sorry, my brain is doing some really mental gymnastics to the great ideas you put forward. So thinking about the example of PrEP and then a couple in South Africa, my question is around defining and measuring, not necessarily quantifying, but kind of articulating benefit sharing at a population level, but not from a rights-based perspective. Not all people in our population are made equal or treated equal, even though we may want to. For example, in the case of lenacapavir and other expensive resources, we have too few to give to everyone who wants it or even could use it. So we try to target. And the targets in many cases include, say, young women, 15 to 24-year-olds, or pregnant women. Those have been two populations. However, we are politically not very keen to give it to pregnant young women. It's not politically nice. It's just no one wants to actually say it. So we say young women and we say pregnant women. So when we're talking about benefit sharing, how are we thinking about articulating this at a population level? Within our population, we don't actually treat everyone's rights and benefits equally. How are you thinking of it? And it's just a question in my mind. And then when one then negotiates backwards for research, how could we think about that? You may not have the answer, but it's just, yeah.
I have a slide.
Okay, go ahead. While you're coming up, what I will say is that perhaps we should draw on the experience of antiretroviral access. You know, there was a lot of political pushback in different ways, and things changed. So what the situation as it applies now doesn't have to be the situation forever.
Okay, so the slide didn't make it onto this deck. But so I think we're also thinking of this maybe at one level up. So there's an article by Tian Johnson and Fatima Hassan published on Health E, the website. And it takes the example of Lenacapavir, and their argument is that we might have issued a tender for a local manufacturing license, but there's a whole ecosystem of potential benefits that have been ignored. So, price caps, that the license being issued shouldn't actually be at the discretion of Gilead. It should be that the government has control over the license, et cetera, et cetera, et cetera. And so there's a two-layer distributional problem. I think one is at the level of sovereign governments and the benefits they negotiate for. And then at the sub or within the nation, it's about allocation of those resources. But hopefully if we get the benefit sharing in place, we can produce at volume sufficient to reach more people within the country.
It's just that the research is targeted, right? I'm not arguing with it, it's just that the research has been done on the bodies of these young women.
Exactly.
So it's,
Sure.
And we're not learning from treatment, sorry, just to say we're not.
Okay. The lessons of tech.
Yeah.
Cynthia, do you want to comment?
Yeah, I think just to speak to the aspect of having benefit sharing arrangements or even just benefit arrangements for research that doesn't necessarily lead to an intervention, because sometimes we expose communities to risk. And that intervention comes 20, 30 years down the line, the community doesn't even recognize that it's part of that initial scheme. And so in the genomic space, Gilead Bio has come up with a model that is something that perhaps other teams can think about, because there's no really direct benefit in genomics, but it is also a commercial company. So they work with the export project in Mpumalanga, and they have benefits at different levels. So the first is that there's a profit arrangement embedded in the proposal itself. So it has nothing to do with your community engagement and all of that. You allocate part of a proportion of your research budget to benefits that the community will tell you what they want. It may or may not be linked to the study. So in this case, in Mpumalanga, they requested for Georgia tanks because the community doesn't have water. And they requested for an elderly home, nothing to do with the initial study itself. Then there is a second layer.
So Cynthia, there's a lot of interest online on what you are saying. Would you mind repeating it at the computer? Because I'm transcribing it really badly.
I'll tell you what, I'll try and summarize it while you come up. But so Cynthia's talking about the field of genomics, where there's been a lot of movement to ensure that genomic trials right into their protocol a priori benefits to the community that the community decides on, and might or might not be related to the actual research topic, like JoJo tanks for water stressed communities and services for the elderly. And now you can go.
And of course there are arguments about whether the community really knows the benefit, really knows the value of their data, but at least there is that first layer. Then there is the second layer, where if any of their data moves into the R&D pipeline, then there is a proportion of the profits that goes to them. So they own a proportion of the shares of any profits that will come. But if they then make profit, so besides that level, if they then make profit above a certain level, then the percentage of their shares changes. So it gives that opportunity for a community that's involved in risk to benefit, even if it doesn't end up in an intervention that's commercializable, but also that if it ends in that level, they also have a say right from the beginning. So that's very contractual. But I think the community likes it. Of course, there are ethical arguments about whether the community has the power to negotiate fairly, but I think that's another level of thinking.
Sorry, Cynthia, before you go, Kwan had a question earlier which asks, can capacity building be considered a benefit? What your response to that would be?
Yeah, so I think sometimes, just a few years back, we did and I think someone talked about the economic benefits that hotels got and all of it. We did ask researchers what constitutes a benefit in terms of benefit sharing. If there is the monetary and the non-monetary aspect, what will constitute benefit to communities? Because you don't generally think about benefit sharing to the direct participants. It will be to the community as a whole, whether or not I participated in that research. And so researchers did see capacity building as one, and to think about the economic benefits of research itself. If you think of the proportion of soft-funded staff that run the university and what that means for income that comes into the university and who benefits from that. So that could be a benefit as well. But I think what we learn from that is you give the communities the power to decide what it is they want. We don't necessarily decide as researchers. Sometimes we think they're interested in that medication file up there, but they just want access to water. I think we talk about this for Lassa fever, for example, in Nigeria. Sometimes it is just access to basic hygiene, it's level of primary health care, and that will be sorted. But we're thinking far more about interventions that we don't even know when it gets into the R&D pipeline.
Okay, thanks, Cynthia. Are there any other comments online, questions? Hannah.
Just a bit of a concern. I fully agree with all that has been said about benefits to communities. My concern is of an unexpected impact. That could be that communities begin to see themselves in a specific way and actually become gatekeepers, and that only research projects that are likely to have a certain output and that are likely to have the financial means to provide benefits are those that are going to be successful. So that's just a bit of a concern of an unexpected impact.
Okay, that's a reality check. Can I just check people online heard the comment, which was about creating a perverse incentive for community or individuals in communities to be gatekeepers around what kind of research is done. If it doesn't have direct benefits in a particular way, it might not be supported. So, any other comments or questions? Okay, if not, then I'm going to close the noon meeting seminar. Thank everyone who attended online and in the room. And if anyone needs continuing professional development credits, there's a book here that you sign. And thank you all. Just to advertise, the other epsilons at UCT will be having a launch of all the 4 epsilons, either on the 11th of May or the 21st of May. We're still finalizing when the Deputy Vice Chancellor will be available. It will be a launch in midday, more or less, sometime. Okay, so watch that space. Thank you, everyone, and thank you to everyone online.
Thank you. Bye.
Bye all. Bye-bye.